So this will be the first of two talks on cystic fibrosis. This is the most common life-limiting genetic condition among Caucasians, and as you know, Caucasians make up the majority in the U.S., and so you can expect that the USMLE will ask you a question on cystic fibrosis. It is also very common in general if you're working anywhere in where there's a high Caucasian population, so U.S., Canada, Western Europe, etc. So we'll go ahead and talk about this. So even though we're talking about cystic fibrosis in the pediatric section, you do need to be aware of this even if you're working in adult medicine. So I work in adult medicine. I've seen several patients with cystic fibrosis, and the reason for that is that the life expectancy now is about 37 years old. And that is because of our more sophisticated treatment, whereas 20 years ago, the life expectancy was not much older than 18. Now it is into the late 30s. So be aware of this for clinical practice, regardless of whether, certainly if you work in pediatrics, but also if you work in adult medicine too. All right, so I divide this up into two sections. Part one is going to focus on what cystic fibrosis is, how you go about diagnosing it, how it can present. Part two is going to focus more on treatment and complications. So cystic fibrosis is a multisystemic inherited condition. It's autosomal recessive, meaning both parents have to be carriers. However, like most genetic diseases that are autosomal recessive, the parents don't necessarily know that they're carriers for cystic fibrosis. The carrier rate is about 1 in 30 to 1 in 35 among whites. However, the incidence is only about 1 in 3,500. So you have to have two parents together that are both carriers. And the odds of that are much slimmer than just simply being a carrier. So you can't rely on family history for really any autosomal recessive disease, not like the autosomal dominant diseases where if a child has it, the parent had it. Okay, so this is a mutation of a protein called CFTR. This gene is on the long arm of chromosome 7, and CFTR just stands for cystic fibrosis transmembrane conductance regulator, and that is a chloride channel. It's ATP regulated. And this is the protein that is mutated when you have a patient with cystic fibrosis. It's on the long arm of chromosome 7, as mentioned. I have seen some USMLE World questions that have asked that specific question. So they give a vignette of a patient with cystic fibrosis, and then they surprise you with a question asking something along the lines of which of the following chromosomes is the most likely mutated. So you should remember that the CFTR gene is on chromosome 7. There are not a lot of questions on the USMLE that will specifically ask you the gene that's mutated in a particular disorder, but this is one of them. So the most common mutation for CF is on the 508th residue of the CFTR gene, and it's a full deletion of phenylalanine. But there are several known mutations that cause cystic fibrosis, and this particular mutation will lead to an absence of CFTR, total absence. But there are some mutations that will cause a CFTR protein that does function, but just to a very small degree. And so there are varying degrees of cystic fibrosis. But this mutation, this total loss, is the most common. So as mentioned, this is the #1 life-threatening recessive genetic trait among whites. The incidence is 1 in 3,500. It is much less common in other racial groups. However, it is still relatively frequent compared to even some other genetic disorders. So among Hispanics, it's 1 in 9,300. Among blacks, it's 1 in 15,000. So certainly just because this is most common among whites, you cannot ever rule it out for anybody. Cystic fibrosis is noted by an ongoing chronic lung disease, exocrine pancreas insufficiency, and overall thickened secretions. If you remember, thickened secretions bogging down the lungs, thickened secretions bogging down the pancreas, you really get a good idea of how this kind of works. So the physiology. So we talked about that CFTR gene that codes the CFTR protein. And there are two theories as to how cystic fibrosis actually is manifested or how the pathophysiology works based on a non-functioning of that CFTR protein. The one that I find most compelling is this low airway surface liquid hypothesis. There's another theory, but I'm just going to go into this one in particular because I think that this is the best explanation. So the CFTR regulates chloride out of the cell. And here we're talking about lungs here, so into the pulmonary airway fluid. And so what happens is if you have a CFTR protein that is not working, then you're going to have less chloride in the lung secretions. And because you have less chloride in the lung secretions, there's going to be a positive net charge. That positive net charge is going to draw sodium back into the cell through this ENaC channel. And so because you're drawing sodium back into the cell and out of the airway fluid, you're also drawing water back into the cell. And so that is going to thicken the airway surface liquid, and you result in a more viscous secretion in the lungs. And there are other theories, and really none of them totally explain everything that happens in cystic fibrosis. One thing that this does not necessarily explain is why these patients are susceptible to Pseudomonas. And the theory that I've heard as to why these patients are affected by Pseudomonas is because the lower, I believe it's the lower or the higher osmolarity of the fluid will result in a decrease in the intrinsic immune pathways in the airway liquid, and that results in increased ability of Pseudomonas to colonize. So I'm not exactly sure how that works. I don't think anybody really is, because we have these competing theories. But really, the main thing to draw home is that because of this inactive CFTR channel, you get a thicker airway surface liquid. Okay, so this is just another picture showing how that works. So you get less chloride into the airway surface liquid. You're going to get sodium drawn back in because of the net positive charge in the liquid, and so that's going to draw water in as well and thicken the liquid. And the impaired mucociliary clearance leads to infection, which leads to chronic inflammation and airway damage. So it's going to be difficult to clear stuff out of your airways because you have a thickened fluid, and that thickened fluid just being more viscous just does not, you can't cough that up as easily. And so that is prime ground for infection because the bacteria are allowed to stay in the lungs and colonize, whereas in normal people, you cough it up. So these are the vast array of manifestations for cystic fibrosis. I wouldn't memorize all of these, but definitely remember the ones in the red. So our pulmonary complications are vast, but bronchiectasis, bronchitis, bronchiolitis, and pneumonia are all potential complications. They're really inevitable complications. So pneumonia being probably the most noted, but really any of these, which these are all infectious diseases of the lungs, and they're more likely to happen because of that decreased clearance. Nasal polyps, the USMLE loves to throw that into the cystic fibrosis, so these patients tend to have larger polyps, and several of them. They can develop them. And usually this will happen in the second decade of life, so you're not going to see a baby with nasal polyps. But this can happen as well. Chronic hypoxia will sort of develop later on as these patients start to decompensate and their lungs just get less functionable. So I kind of put these in order of when you would see them, but it's not perfect. All right, GI-wise, meconium ileus, this is cystic fibrosis until proven otherwise. This, of course, will manifest as a failure to pass meconium. Meconium plug syndrome can also happen, and then rectal prolapse is uncommon, but with cystic fibrosis, it's much more common. So I would also say that rectal prolapse would be a strong indicator of cystic fibrosis, just because it does not really happen in normal children. So a lot of these other things you'll see later on. So some important ones here are cholelithiasis. Again, you're going back to thickened secretions. And what is bile? Bile is a secretion. And so if that's thicker, it makes it much easier to develop stones. Pancreatitis, again, we're talking about thickened secretions, and the pancreas is an exocrine organ. And so you have thicker secretions, you can get infection. Insulin deficiency can happen just due to the insults on the pancreas. About 30% of patients with cystic fibrosis by age 20 or older than age 20 actually have some level of insulin deficiency. Neonatal obstructive jaundice, biliary cirrhosis, biliary atresia, they're a little bit less common, a lot less common than meconium ileus, but they can also happen, again, because of thickened secretions, which ultimately, thicker bile leads to biliary cirrhosis. In general, these are two important ones to remember. Failure to thrive, so remember that we have a pancreas issue to some degree, and that's going to result in decreased amylase, decreased lipase, decreased proteases, and that means that it's going to be difficult to break down fats. That's going to lead to steatorrhea, which I probably should have. Did I put it on here? No, I did not put it on here. Okay. So steatorrhea is when you have fat in the stool, and that fat is not being digested, not being absorbed, and so you get less calories digested and absorbed than you took in. And so you put these children with cystic fibrosis on a regular diet because they're not diagnosed. They don't absorb as much of those calories, and they wind up small and failing to thrive. So that has to do with the decreased ability to digest and absorb because of the pancreatic dysfunction. Vitamin deficiency, again, you're along the same lines here. We're talking about A, D, E, and K. Those are fat-soluble vitamins. So if you're not digesting fats, you're not getting in A, D, E, and K. And those vitamin deficiency symptoms can be anything that A, D, E, and K do. So if you don't have vitamin A, you can get night blindness. If you don't have vitamin D, you can get osteoporosis, etc. Delayed puberty. Not exactly sure why this happens, probably something along the lines of the fact that these patients tend to be thin, and being thin tends to delay puberty. It's not by much, about 2 years on average. They'll be behind their peers, but they will ultimately develop normally. Infertility is much more common among men. It's pretty much universal because patients with cystic fibrosis have bilateral congenital absence of the vas deferens. Females with cystic fibrosis are more likely to be infertile than other females. However, they certainly can get pregnant. And I have actually personally cared for a pregnant cystic fibrosis patient. Actually, the very first cystic fibrosis patient I ever cared for, this is when I was a medical student, she was actually pregnant simultaneously. Hypoproteinemia, because of the decreased proteinase, you're not absorbing as much protein. That can also lead to edema as well. Dehydration is common, again, because of issues with the channels. You're excreting out more water. Hypertrophic osteoarthropathy, I have no idea of the mechanism behind that. Endocervicitis, this is again because of secretion issues, which creates a much more favorable environment for the proliferation of bacteria. Amyloidosis is another one, and then skin wrinkling. And again, I believe this has to do with that chloride channel. So I don't know what the exact mechanisms are for all of these, but just know the ones in the red. Those are the most important. I would probably put pancreatitis and steatorrhea in red too. I could go back and redo this, but here you have it. Okay, so the presenting feature of cystic fibrosis, so this is when a patient comes in or a parent brings patient in with a particular complaint, and ultimately this chief complaint leads to a diagnosis of cystic fibrosis. So you can see that the most common, even though we have newborn screening and it's universal, mandated by law, and we do it in all the hospitals, even though we have the newborn screening and even though it's really good at detecting cystic fibrosis, still, the most common presenting feature, maybe within the margin of error, but still on this study, the most common is acute and persistent respiratory symptoms, and that's going to be several diagnoses of bronchitis in the patient's history, or maybe misdiagnosed as bronchiolitis if they're really young. So look for, in the patient's history, multiple, more than normal, multiple diagnoses in the past of respiratory issues, bronchitis, bronchiolitis, pneumonia. The next most common is the newborn screening abnormality, but important to remember that the screening test that we do for cystic fibrosis is only tests for 90% of the mutations, so of the known mutations. So it's only got about a 90% sensitivity. That leaves 10% of children out. So this is common to catch children on the newborn screening exam, but just because they had a negative newborn screening does not mean they don't have cystic fibrosis. Failure to thrive and malnutrition is the next most common, about 18.7%. Meconium ileus. Remember, if any child has meconium ileus, you are thinking cystic fibrosis. So about 30, I believe it's like 30% of cystic fibrosis patients will have had meconium ileus. And then we talked about abnormal stools, steatorrhea. They float. They're particularly foul smelling. That's what they all say. But in my opinion, all poo smells bad. So I really don't know what they mean by abnormally bad smelling stools. But you can sometimes see micelles in the stools, those little fat droplets. So that's going to be a possibility. You'll always, in any case, when you have a parent complaining about baby stools, you want to get a stool study if it sounds unusual, and you should be able to get a positive fecal fat on that. And at that point, if they have any other suspicious symptoms, you'll go ahead and get a sweat fluoride test. Family history comes in at about 12%. Nasal polyps, sinus disease, like I said, nasal polyps tend to occur in much older children with cystic fibrosis, so that's why this is a little less common. Rectal prolapse is not common in general, even among cystic fibrosis patients, but if you have a child with rectal prolapse, you really should be looking at cystic fibrosis because rectal prolapse, even among normal children, is very rare. Hepatobiliary disease and electrolyte base disturbances, and then other. These other include several different things. All right. So this is, I'm not gonna go over this again, but this is sort of these manifestations when they happen. So there are things that happen later on that don't necessarily happen earlier. So it's very unusual for a baby getting diagnosed with cystic fibrosis to have things like hemoptysis and pneumothorax. These things are diseases that occur because the parenchyma of the lung had been damaged, and that's usually the last to go. That's a later manifestation. This is kind of the progression as to when these happen. But you can see some things on here are really universal with age. So infection, dehydration, this hyponatremic, hypochloremic metabolic alkalosis, which is most likely to happen when a patient has a GI bug or when they are sweating a lot, hot weather, exertion, and so forth. And then blockages of the GI tract. So meconium ileus during infancy, really during neonatal period, and then things such as intussusception, DIOS, which is distal intestinal obstructive syndrome. These are both obstructions, lead to obstruction of the bowel. Okay, so the manifestations as far as the respiratory tract, cough is the most constant symptom, so it certainly is not necessarily going to be the presenting chief complaint, but it is something that sticks with the child throughout their life because they have excess thick mucus, difficult time coughing that mucus up, and so it's going to lead to a cough. That cough tends to be worse in the morning or after activity, and this sort of makes sense. So in the morning, you're laying there, the mucus has more time to sort of impact and thicken up. You're also somewhat dehydrated when you wake up, and so that also contributes. And then after activity, probably for about the same reason. Wheezing may present, especially in young children. Again, you can never forget this fundamental aspect of children, the very, very young children, is that they have smaller airways. And smaller airways means much less ability to deal with obstruction because resistance is proportional to the inverse of the fourth power of the radius, Poiseuille's law. So wheezing can be present, especially in the very young children under 2 years of age. Like I said, often this is misdiagnosed as repeated episodes of bronchiolitis, acute bronchitis, and pneumonia, so look for that in the patient's history. Later on, these patients go on to develop exercise intolerance, shortness of breath, failure to thrive, nasal polyps, and obstruction if they're not diagnosed. Nasal polyps and obstruction can develop even if they are diagnosed. There's really no way to prevent that. And then in severe cases, much later on, cor pulmonale, respiratory failure, and then what we're always worried about, and which is really inevitable, is colonization with opportunistic pathogens. What we're talking about here primarily is Pseudomonas, and to a lesser degree, Burkholderia cepacia. In the GI tract, of course, during infancy, meconium ileus is common, 10 to 15%. Okay, so I overshot that. I thought it was about 30%, but 10 to 15%. So that's pretty common in that's among all cystic fibrosis patients. So about 85 to 90% of cystic fibrosis patients will not have had a history of meconium ileus. But when you have an infant with meconium ileus, failure to pass meconium, your mind is immediately tuned in to CF. Thickened meconium can result in failure to pass meconium. I already talked about that. Then other things that can happen is meconium plug syndrome because of the thickened meconium, and then meconium peritonitis. During childhood and beyond, we already talked about DIOS. That leads to cramping, abdominal pain, and distension, pretty much just like any other intestinal obstruction. And then malabsorption because of the decreased pancreatic lipase. That leads to a steatorrhea, fat in the stool. The decreased absorption of fat leads to failure to thrive. The decreased absorption of protein leads to a hyperproteinemia. And then the decreased absorption of fat leads to a decreased absorption of fat-soluble vitamins, and those are A, D, E, and K. And so if you remember back to the growth and development section, the hypovitaminoses of the fat-soluble vitamins, a low amount of vitamin A can lead to night blindness. It can also lead to those little white spots on the eye, which is called a Bateau spot. You can also get keratosis of the, usually it's of the arms and elbows but it can happen elsewhere too. Hypovitaminosis D usually just leads to a decreased bone density, which can be particularly problematic for girls, especially when they hit puberty, because they have a tendency to develop sort of an osteoporotic state during that period anyway. Cystic fibrosis very rarely leads to actual frank rickets, so that's not something that we usually see. Hypovitaminosis E tends to just lead to a hemolytic anemia, dementia. That's not common, by the way. Hypovitaminosis K, now this is actually relatively common, can lead to a prothrombemia. So anytime you have a bleeding episode in a cystic fibrosis patient, you should be getting a ProTime, and then, of course, bleeding. That is subsequent to that. So biliary tract, in the infant, it can lead to neonatal obstructive jaundice because of the thickened bile. It can also cause biliary atresia and stenosis. Those symptoms should be pretty apparent when you're dealing with a neonate. You'll have jaundice. You'll get a differential on the bilirubin, and you'll see that you have an increased conjugated bilirubin. During childhood and beyond, if they do have cirrhosis, it can ultimately lead to portal hypertension, ascites, and varices. This is important because you can have hematemesis later on, and this is very deadly with hematemesis. Okay, hypersplenism is really just due to the cirrhosis, and then biliary colic. That has to do with the fact that cystic fibrosis patients have a tendency to develop gallstones because of the thickened bile. And so the gallstones can lead either to having obstructive gallstones or just having the gallstones in the gallbladder, which can cause a biliary colic. The GU tract, we already talked about the delay of puberty, roughly about 2 years. Males will have azospermia, about 95%, and that's related to the vas deferens issue. And then undescended testes, inguinal hernia, and hydrocele can develop. These are much less common, these things, except for the infertility. Females can have secondary amenorrhea, probably due to a malnutritious state, and then they can also have endocervicitis as well. As far as the pancreas, remember that these patients are prone to develop hypoinsulinemia, and so of course what's that going to lead to? Pretty much similar symptoms to what you have with type 1 diabetes mellitus, so hyperglycemia, glucose in the urine, polyuria, and weight loss. Acute pancreatitis can happen in some patients, and in those patients it tends to be recurrent, but these are, again, are a minority of patients. 8% of patients 11 to 17 years of age and 30% of patients older than 25 years of age will have CF-related diabetes. If this is not controlled, this can lead to your typical complications of diabetes, retinitis, kidney and vascular complications, and this typically takes about 10 years after onset if it's not treated properly. By then, usually the patients are getting towards the end of their life expectancy, so this isn't really something that we deal with a whole lot in cystic fibrosis patients, but just remember that this is a possible complication, and you really need to keep an eye on this if this was a patient who developed their CF-related diabetes much younger in life. The sweat glands. So we don't really think of the sweat glands a whole lot when we're thinking about complications, but I wanted to bring up the sweat glands here because what's behind this whole salty baby thing? So you always hear about cystic fibrosis and the salty baby. So this is also going to be important when we talk about one of the diagnostic tests, indeed the best diagnostic test for cystic fibrosis, which is the sweat chloride test. Now, you might be thinking, well, I thought that cystic fibrosis, being a mutation of the CFTR gene, which is codes for a chloride channel, causes decreased transport of chloride. And indeed it does. It results in decreased transport of chloride. But when we're talking about the lungs, as we already mentioned, you're talking about chloride being secreted into the airway fluid. So you have no channel, you don't get the chloride into the lung fluid. In the sweat glands, the chloride channel is responsible for reabsorbing the chloride. And so if you don't have a channel, you're going to have excess chloride in the sweat. So in the lungs, the chloride channel secretes the chloride. In the sweat glands, it actually reabsorbs the chloride. So you don't have the channel, you have more chloride in the sweat. Increased excretion of chloride can result if you have excess sweating. And so during exertion, it can lead to hypochloremia, and that itself can lead to hyponatremia, and then the hyponatremia affecting the sodium proton transporter in the distal tubule will result in a metabolic alkalosis. For more on that, see the renal section. And this is what's behind that hyponatremic, hypochloremic metabolic alkalosis. So hopefully we nailed down here why you get excess chloride in the sweat. So the channel is working in the opposite direction of the sweat glands. Of course, this is exacerbated by warm weather because that's going to lead to more sweating, and also exacerbated by gastroenteritis because that results in a dehydrated state. So hydration is going to be key in managing cystic fibrosis to prevent some of these complications. So what do we do for diagnosis? Typically, when a patient is, when we start to suspect cystic fibrosis, it's because of one of three things. Either they have those typical clinical features, a history of repeated respiratory tract issues, or perhaps meconium ileus, or it might be because these are two parents who have had a previous child with cystic fibrosis. That is certainly a red flag too. Or maybe it's because they didn't have any of these, but they had a positive newborn screen. Any of these three are an indication to do a further workup for cystic fibrosis. So if you have one of these, you're going to do typically a sweat chloride test. But there are three different things that you can do. You can do a sweat chloride test, and if you do a sweat chloride test, which is the most accurate test, so it should be your go-to test, you need to get two separate positive readings on 2 separate days. So not just one, you need 2. You need to do it Monday, you get a positive result. Okay, we're going to do it next Monday again, or on Friday. You need 2 separate sweat chloride concentrations that are elevated above 60 milliequivalents per liter, which is positive on 2 separate days. You can also do a genetic analysis, but this is not commonly done, and you would identify 2 CF mutations. Of course, that is diagnostic as well, but the problem with this is that we don't know all of the cystic fibrosis mutations. We're discovering new ones every year, so this is not always perfect. Now, there are some genetic diseases where it's always the same mutation. And in that case, DNA testing is great. But in cystic fibrosis, we do not know all the mutations, or at least we aren't sure that we know all the mutations. So the sweat chloride test is the best. There is another way to test, and that is the nasal potential difference. Usually this is reserved for when you have a sweat chloride test that is equivocal. You can do this as well. So sweat chloride testing, a lot of times this is not, it doesn't really work very well in very small babies, but once they're a couple months old, you can do this. What you do is you use pilocarpine, and that induces sweating, and you can really do this anytime after 48 hours of life. You don't need to memorize these readings exactly. I just wanted to point out that for clinical practice, there is a range. So it's not just a perfect cutoff between negative and positive, but certainly anything above 60 milliequivalents per liter is positive. So anytime you get a positive result, you're going to repeat the test on another day. And a second positive reading is diagnostic when it is in conjunction with clinical features, family history in a sibling, or a positive newborn screen. And these are the 3 things that are going to make you want to do a sweat chloride test to begin with. There are some conditions that can cause false positives, and they're really just a collection of random syndromes, so congenital adrenal hypertrophy, adrenal insufficiency, Klinefelter's G6PD deficiency, nephrogenic DI, hypothyroidism, and familial hypoparathyroidism. So just sort of this random hodgepodge of diseases. I wouldn't memorize this for the test either. Just be aware that you can get false positives. And then also note that there are some variants of cystic fibrosis that have preserved sweat gland function. That is not your common mutation, but there are some mutations that do lead to CF with preserved sweat gland function. And so these will render, of course, false negatives on sweat gland testing. This would be probably one of the cases where you would want to do a DNA analysis to look for a mutation on genetic testing. Ultimately, however, cystic fibrosis is always going to be a clinical diagnosis in conjunction with your lab.